Hello, my name is Trista Anderson, and my chronic illness case study is going to be over DiGeorge syndrome. So I'll get started with talking about the case presentation. So the case study patient is a 24-year-old white female. She lives at a neurological institute where she receives specialized care. Her mother and stepfather work full-time and are her primary emotional support. She also has an older brother, a younger half-sister, and 4 step-siblings who offer support often. She has access to a medical center where she receives specialized care when necessary. No financial constraints or transportation challenges are present. So her health history, she has a history of congenital heart disease, a developmental delay, seizure disorder, scoliosis, vision impairment, and hypoparathyroidism. Her current medications that she takes every day are calcium carbonate, vitamin D, Keppra, and aspirin. Her surgical history is tetralogy of Fallot repairs. She had ear tubes and multiple G-tube placement and replacement surgeries. She has allergies to chlorhexidine, vancomycin, and home treatments. She does have a feeding regimen that she follows using her gastrojejunostomy tube, and she also does physical therapy as well. And this isn't on my slide, but she also does have a respiratory plan if she happens to get sick. Sometimes she needs a sick plan. So they have that in place as well. So analysis and solution options. So DiGeorge syndrome results from a microdeletion on chromosome 22 at the Q11.2 region. This deletion disrupts embryologic development of structures derived from the 3rd and 4th pharyngeal pouches. So one of the most important genes affected is the TBX1, which plays a key role in pharyngeal arch and neural crest cell migration. When this gene is underexpressed, the thymus does not fully develop, leading to impaired T-cell maturation and varying degrees of immunodeficiency. The parathyroid glands may also be underdeveloped or absent, resulting in hypoparathyroidism and low calcium levels, which can cause seizures or cardiac arrhythmias. Neural crest cell dysfunction contributes to cardiac defects, and additional systems such as craniofacial, neurological, and renal systems may also be affected, making this a multi-system disorder. The primary cause of DiGeorge syndrome is the heterozygous deletion of chromosome 22q11.2, which typically occurs during meiosis as a result of abnormal chromosomal recombination. The majority of cases, about 90%, are sporadic, meaning neither parent carries the deletion. Approximately 10% are inherited in an autosomal dominant pattern, which is important for genetic counseling. The deletion removes several genes involved in embryonic development, most importantly the TBX1, leading to abnormal formation of the thymus, parathyroid glands, and heart. In rare instances, patients may demonstrate a DiGeorge-like phenotype without a 22q11.2 deletion, suggesting alternative genetic pathways can produce similar clinical features. DiGeorge syndrome is the most common chromosomal microdeletion disorder with an estimated prevalence of 1 in 3,000 to 4,000 live births. It affects individuals across all racial and ethnic backgrounds equally and does not appear to favor one gender. Many cases go undiagnosed or are diagnosed later in life due to the wide range of severity, from life-threatening cardiac or immune disease in infancy to mild learning or psychiatric issues in adulthood. Detection rates have improved significantly due to chromosomal microarray testing and newborn screening for severe combined immunodeficiency. As medical care improves, more individuals with DiGeorge syndrome are surviving into adulthood, increasing long-term healthcare needs. So assessment of DiGeorge syndrome requires recognition of both subjective symptoms reported by the patient or caregivers and objective clinical findings identified through physical exam and diagnostic testing. Subjectively, patients or caregivers often report frequent or recurrent infections, which result from underlying T-cell immunodeficiency. Feeding difficulties, poor weight gain, and fatigue are also common concerns, especially in infancy due to cardiac defects or palatal abnormalities. Symptoms of hypocalcemia, such as muscle cramping, tingling, or seizures, may also be reported. Additionally, caregivers may note developmental delays, learning difficulties, or behavioral and mental health concerns as the child ages. Objectively, healthcare providers may identify congenital heart defects such as murmurs or cyanosis during physical examination. Characteristic facial features such as low-set ears, a small mandible, or wide-set eyes may also be present, although these can be subtle. Lab findings may reveal hypocalcemia due to hypoparathyroidism and low T-cell counts due to thymic hypoplasia, confirming immune dysfunction. Additional findings include cleft palate, speech abnormalities, poor growth, hypotonia, and delayed developmental milestones. Diagnostic testing such as echocardiography, calcium levels, immune studies, and genetic testing supports the diagnosis. So here's a current medication with mechanism of action and rationale. So this patient is on calcium carbonate. That's to provide calcium to support neuromuscular and cardiac function. And this is to treat hypocalcemia caused by hypoparathyroidism. The next one's vitamin D, which increases the intestinal absorption of calcium and regulates calcium phosphate balance via vitamin D receptors. And this helps maintain calcium when parathyroid hormone is deficient. The next one there is Keppra, which is used to stabilize neuronal activity, which is to prevent seizures. And aspirin is on there to prevent platelet aggregation and reduces this patient's risk of thrombotic complications. So now on to recommendations, final plan implementation. So diagnosis of DiGeorge syndrome is guided by APP or AAP and International 22Q11.2 guidelines. It begins with clinical suspicion based on characteristic findings but requires confirmation with genetic testing, typically the chromosomal microarray. A full multi-system evaluation is then performed to assess cardiac, endocrine, and immune involvement. So some recommendations for change for this patient is to improve seizure management. The patient does have occasional breakthrough seizures, not often, but it does happen. So I would say just to improve the seizure management plan to hopefully prevent this from happening. And another thing that might help with this as well is the frequent calcium monitoring. This patient does not have like a routine calcium monitoring. They just check labs when she goes in for follow-up appointments with different specialists, but not on like a set routine. So calcium levels could be leading to these occasional breakthrough seizures. So having a more frequent calcium monitoring or some type of routine could help with this. I also just put to continue physical therapy. Caregiver who helped with the information for this case study said that they sometimes get pushback about physical therapy for her, but I think it's important just to keep from declining functionally for her. And then another one I put on here is to ensure infection prevention is being practiced within the facility to ensure that the patient is not getting unnecessarily ill, since she is immunosuppressed due to her illness and living in a facility. It's just important to make sure that she's not getting illnesses from other patients there. So for education, Patients and caregivers should understand that DiGeorge syndrome is a genetic condition caused by a chromosomal deletion and is not preventable or contagious. Although there is no cure, symptoms can be managed effectively with medical care, as you can see that this patient and their family has been doing. Due to immune system involvement, education should emphasize infection prevention. So for this patient, that's going to include educating staff at the facility, including good hand hygiene, avoiding exposure, and recognizing early signs of infection, such as fever or a persistent cough. Continue management of hypocalcemia is another key focus. Caregivers should recognize symptoms such as numbness or tingling, muscle cramp, seizures, or irregular heartbeat. And everyone taking care of the patient should know the importance of the calcium and vitamin D supplementation. And then for individuals with the congenital heart disease, just reinforce the need for regular cardiology follow-up and early report of symptoms such as shortness of breath, fatigue, or cyanosis. This patient does have developmental delays, learning difficulties, which is common in patients with this syndrome. So education should just be provided on the importance of physical therapy. And patients should understand that this syndrome requires lifelong monitoring and follow-up care. Individuals with DiGeorge syndrome require regular and lifelong follow-up care. Due to the condition's multi-system involvement and variable clinical course, follow-up should be coordinated through a primary care provider who oversees routine health maintenance, ensures timely referrals, and facilitates communication among specialists, which it sounds like this patient does have that. Like I said, the only suggestion I would make would be to increase or have a better plan for checking those calcium levels. And then an immunology follow-up to monitor the T cell function, infection frequency, and the cardiology follow-up for patients with congenital heart defects, which this patient does have one. And then endocrinology visits to monitor calcium levels and parathyroid function, especially after a seizure. And then just routine developmental follow-up to improve long-term outcomes for this patient. And then obviously genetic counseling to discuss inheritance patterns, recurrence risk, and family planning if the family wishes to. Recommendations, final plan implementation. So chronic illness management for individuals with DiGeorge syndrome requires a lifelong multi-system approach due to the broad variability in clinical presentation and severity. Symptoms may involve the immune, endocrine, cardiac, neurologic, and psychiatric systems, and these manifestations can evolve over time. Care plans must be highly individualized, as no two patients experience syndrome in the same way. Nurses play a key role in coordinating care among multiple specialists. Ongoing monitoring is essential to identify emerging or worsening complications such as recurrent infections, hypocalcemia, cardiac issues, autoimmune disorders, and neuropsychiatric conditions. Nurses should promote self-management and education as a critical nursing responsibility for families so that they are empowered to understand, recognize warning signs, adhere to medications, and seek timely medical care. Psychosocial and developmental considerations are also central to chronic illness management. Individuals with DiGeorge syndrome are at increased risk for learning disabilities. Early mental health screening and appropriate referrals can significantly enhance the quality of life. And finally, just the care transition from pediatric to adult healthcare systems. Nursing practice plays a critical role in the management of patients with DiGeorge syndrome due to the condition's complex and multi-system nature. Early recognition of clinical manifestations, including recurrent infections, hypocalcemia, congenital heart disease, and developmental delays, is essential for timely diagnosis and intervention. Ongoing assessment of immune function is a key nursing responsibility. This includes monitoring for signs of infection, reinforcing infection prevention measures, and ensuring immunization schedules are followed appropriately, with consideration for live vaccine restrictions based on immune status. Nurses must routinely monitor calcium levels, particularly during times of physiological stress or illness. Prompt recognition of hypocalcemia symptoms such as seizures, muscle cramping, or cardiac irregularities. This allows for rapid intervention and prevention of complications. Effective care for individuals with DiGeorge syndrome requires strong coordination among multidisciplinary healthcare teams, which could include cardiology, endocrine, immunology, genetics. Nurses serve as key care coordinators, ensuring continuity across inpatient, outpatient, and community settings. Family education is essential and should address disease understanding, medication management, signs of infection, and the importance of routine follow-up care. Nursing care should adopt a lifespan approach. As individuals with DiGeorge syndrome increasingly survive into adulthood, nurses play an important role in facilitating transitions of care, addressing psychosocial needs, and advocating for long-term monitoring of neuropsychiatric and autoimmune complications. And here are my resources.